Hi, my name is Suzanne Johnson and I'm a gynaecologist from Southampton. Thank you for asking me to talk about the role of 3D ultrasound in an ambulatory setting. 3D transvaginal ultrasound is extremely useful in all these different scenarios. In the setting of an ambulatory clinic, I'm going to focus on discussing these different indications for 3D ultrasound. The most important application for 3D is in deciding what shape the uterus is. You can decide what shape the uterus is on MRI or on a combination of laparoscopy and hysteroscopy, but 3D transvaginal ultrasound has shown to be extremely good at this. What you need to obtain is a coronal view, because that distinguishes between the various congenital uterine anomalies. The coronal view is the plane in purple in this image, which divides the body into a front half and a back half. How to get such a good view? Most importantly, to do this in the luteal phase if you can, because then you get a really good endomyometrial contrast. You can do it on transvaginal scan or transrectal, but very importantly, you need to optimize your 2D view. The 3D is only going to be as good as the 2D view, so make sure that you've done everything you can to make that as nice as possible. You then select a region of interest, in this case the uterus, take a 3D volume, and then look at the coronal view in the sectional planes, or render the volume and look at the coronal rendered view. So there's two ways of doing this. You can optimize your image, select the region and take a volume. And this will be displayed on most machines as a longitudinal view, a transverse view, and then a coronal view. This is the uterus on its side, that's the uterine fundus. And then when you render that, it comes out as a rendered coronal view, which you can manipulate in all directions and get really good detail. Alternatively, on some machines now, you can just draw a line on the touch screen like this. I'm drawing the line from cervix to uterine fundus. You could go the other way around, and you can see the machine automatically gives you a rendered coronal view there. Very nice and easy. The way Müllerian duct abnormalities come about is through a problem with the formation of the Müllerian ducts, or their fusion, or the resorption of a septum. Thinking about classification systems, the original American Fertility Society one was from 1988, has been superseded. This classification system from 2003 is very good and useful, and I've used it ever since then. There was an Eshrei-Ezge consensus in 2013, which was controversial, and has now also been superseded by the ASRM classification in 2021, and that's a QR code, so you can do this online yourself. It's a very good classification system. It talks about different abnormalities, about different imaging modalities, treatment, variants on a theme, what it looks a bit like, and it's very good. I'd encourage you to have a look at it. The nice thing for me is that it's still actually the same as this, but it's got a lot more detail in it. And so I'll be talking you through this classification system. So this is a normal uterus seen on 3D. Here you've got the top of the uterus, which is nice and convex, the top of the endometrial cavity, which is flat, interstitial portion of the fallopian tube on this side and the other side. This here is the endometrial cavity going down toward the cervix. This is one side of the uterus and this is the other side. So this is a normal uterus on 3D. This uterus is arcuate. Again, the top of the uterus is convex. There's a bit of a dip in the endometrial cavity, but this should be less than 10 millimeters, and this angle here more than 90 degrees. This is an arcuate uterus. This uterus is subseptate. Again, the same convex uterine fundus. You've got a bigger dip now in the endometrial cavity, so you end up with two horns. This dip has to be more than 10 millimeters, and this angle here less than 90 degrees. This is a subseptate uterus because the septum doesn't go all the way down to the cervix. In a septate uterus, it's like subseptate, but this time the septum goes all the way through into the cervix and maybe through to the vagina as well. Septum length, again, more than 10 millimeters, and this angle, less than 90 degrees. You can, of course, take a separate view of the cervix if you want more detail, and here you can see 2 cervical canals and a septum running all the way through. So high risk of that continuing in the vagina as a longitudinal, an oblique or a transverse septum. In a bicornuate uterus, you've now also got a fundal myometrial dip, as well as the dip in the cavities, the 2 horns of the cavity. This has to be more than 10 millimeters. So you're allowed less than 10 millimeter dip in all the other abnormalities, if you like. But if it's more than 10 millimeters, it's now bicornuate. Uterus adelphus is where you've got 2 entirely separate uterine bodies, but adherent to each other, if you like. Quite difficult to image on 3D because you tend to have one horn pointing one way and the other in a different direction, a bit like bunny ears. So this is what it looks like on 2D, the joint cervices and then one uterine horn and the other, or uterine body. And again, you can image one carefully by itself and then look at the other one and then look at the cervix separately. This is still in 2D, cervical canal, endometrial cavity, cervical canal, endometrial cavity. The unicornuate uterus is the congenital anomaly which is most often missed. On 2D, the uterus looks completely normal in the longitudinal view, and it's subtly different in the transverse view. The cavity tends to be narrower, and this cavity doesn't, like a normal endometrial cavity, become longitudinal. It's almost circular, and that's what should raise your suspicion of a unicornuate uterus. On 3D, it's really easy. It looks a bit like a banana. You have a single interstitial portion of the fallopian tube, and it's a unicornuate uterus. You also have to look for the presence of a rudimentary horn, which may or may not be communicating with the main cavity. As in this example, this is a unicornuate uterus in the transverse plane, and there was a connection, some tissue to a little lump there, which was separate from the ovary. And when I turned the 3D on, it showed up beautiful endometrium. So this is definitely a rudimentary horn and unicornuate uterus. You can have variations on a theme. You can have a combination of abnormalities, and you can have 1 or 2 cervical canals in one cervical body or 2 separate cervices. Septum is important to look for. Difficult to see on ultrasound, but on vaginal examination, of course, it might be a hematocolpos and hematometra. And especially if there's obstructed outflow, there's an association with endometriosis, so we need to look for that. And associated renal abnormalities, especially where you've got an obstructed hemivagina, the Avera abnormality. And that's this one, where you've got a double uterus, and then you've got a septum in the vagina, which is causing complete obstruction on one side, causing a hematocolpos and a hematometra, and you get retrograde menstruation and possibly endometriosis too. And in this abnormality, there's no kidney on the affected side, so important to diagnose. I think of this as Dohvera, but of course it was always known as Herlin-Werner Wunderlich previously. The ASRM has not included the T, Y or I-shaped uteri, and this is a good paper describing that, but this is a controversial topic. Fibroids. These were described very nicely by the Musa group, and they used the FIGO classification of myomas, separating them, of course, into submucosal, where it's a fibroid polyp. More than half present in the endometrial cavity is a grade 1 submucosal fibroid, less than half in the cavity grade 2, or it might be just in contact with the endometrial cavity. Intramural fibroids surrounded by myometrium, a transmural fibroid extending all the way through, and then the subserosal fibroids, whether they are more or less in contact with serosa or pedunculated. So 2D is the main way that we look at fibroids, but 3D can come in handy. This is a subserosal fibroid with quite poor views. It absorbs all the sound waves. You need to go down in frequency and turn off harmonics, then you'll get a better view. Turn on your Doppler, a PRF of 0.6, to make sure that you've only got peripheral flow. In this example, I'm going to show you a mass in the pouch of Douglas, and we need to have a look, see what it is. There is this mass, it's a solid regular mass, and you can just begin to see that there's a connection there to the uterine body. There's the connection and there's the uterine body. So it's something attached to the uterine body by a stalk, and turning the colour on you can see it's very vascular. So I just need to make sure that it's not an ovary, and in this view you can see the ovary is very low in the pelvis just there, but it's totally separate from this mass, and this is a pedunculated fibroid. Intramural fibroids, this one is calcified, you can see quite poor views usually, but this one is surrounded by myometrium, and there's the endometrial cavity in a retroverted uterus. This submucosal fibroid is indenting the cavity, you can see a bit of fluid in the cavity, and it's indenting the cavity by less than half. Of course, you can have a submucosal fibroid polyp. This is a hypoechoic lesion in the endometrial cavity, and it's got a feeder vessel to it. So if you can see something in the cavity with a feeder vessel, it's a polyp, but not all polyps have a feeder vessel. And on 3D, you've got a lovely image here of this hypoechoic lesion outlined by endometrium. It's a fibroid polyp. So the use of 3D can be very handy, have it on standby. There's a calcified fibroid. This is a bit of endometrial cavity. On 3D, it's really obvious what's going on. This fibroid is displacing the cavity sideways. And here again, not 100% clear what's going on, and on 3D it's instantly obvious. It's a big fibroid polyp on a big pedicle. Adenomyosis was redefined by the Musa group last year, and you've got direct features and indirect features. And this is where you have an invagination of the myometrium by endometrial buds, causing cysts and sometimes a hemorrhage into these, and then surrounding inflammation and fibrosis. Cysts, hyperechogenic islands of endometrium, and these lines and buds were thought to be direct features, and then some of these result more from the fibrosis, so that you end up with an asymmetrical myometrial wall and a globular uterus, translesional vascularity, fan-shaped shadowing, and irregular endomyometrial junctions. The difference between a fibroid and adenomyosis is this. A fibroid has a little capsule, and it's a lesion within the myometrium, whereas these are little islands of endometrium in the myometrium and don't have a distinct capsule. The shadowing from a fibroid tends to be a big fan like that, and a solid shadowing behind the fibroid, whereas the shadowing behind adenomyosis, because you have these little cysts that let some sound waves through, you get this stripy shadowing. And if you turn your color Doppler on, you will have vascularity surrounding the fibroid, but it's translesional vascularity through adenomyosis. Adenomyosis can be diffuse, where you get this asymmetrical wall thickness, translesional vascularity, and fan-shaped shadowing. Or it can be focal, as in this example, where you've got these islands of endometrium in the myometrium. We've got these myometrial cysts and hemorrhage within them. There's the hemorrhage, there's that focal adenomyosis, as you can see, but some of the rest of the myometrium looks quite normal, so focal adenomyosis. Sometimes you have both. There's a fibroid, and there on the other side of the uterus was adenomyosis. It looks more clear in a little video clip. On the 3D, there's the fibroid. This is the endometrial cavity, and you can see this very indistinct, blurred endometrium in the myometrium. You can see it more clearly in the video, the difference. So we've got the fibroid here on the anterior wall of a retroverted uterus, and some posterior wall adenomyosis. Sometimes you see this. This is a sort of a transverse oblique view of the uterus, endometrial cavity. There's an ovary, and then what's this? A uterine lesion. It had some flow peripherally. It seemed to have some blood within. This is the cavity. This is the interstitial portion of the fallopian tube, so it's not a pregnancy or anything like that. It's sitting just below it. The 3D uterine shape was normal, a normal fundus, a normal endometrium. And on 3D, the location of this lesion was quite low. This is an ACUM, an accessory and cavitated uterine mass. It used to be known as a cystic adenomyoma, and it can cause intense dysmenorrhea and can be removed and be curative. And it is a Müllerian abnormality just below the interstitial portion of the fallopian tube, but the uterus itself looks normal on 3D, and you need that to make the diagnosis. A couple of examples of that. This patient, you can see there was the abnormality on longitudinal 2D ultrasound. And on 3D, you can see that this, again, is this low-lying hemorrhagic myometrial lesion. She was 17. She didn't want surgery, so she was quite happy on the mini pill for now. But in this other example, that's an arcuate uterus, and here again was this myometrial lesion, and this is what it looked like at laparoscopy. It was excised, and the patient didn't have any pain after that. This is an excellent paper telling you more about ACUMs. What you must think is, if there's adenomyosis, is there also endometriosis? And in this case, we can see the adenomyosis here anteriorly, and I'm going to do a quick ultrasound video here, looking at the internal os. The torus is behind. Rotate on that point. This is torus, this is the right uterosacral ligament. It all moves nicely, but here you can suddenly see the ovary is adherent to the left uterosacral ligament. So there is endometriosis, and we need to look for more. In this example, this is the endometrial cavity. On 3D, you can see this budding of endometrium into the myometrium. And here you can see an endometrioma, a bowel nodule, retrocervical fibrosis, and deep endometriosis, all in this patient with adenomyosis. And this is a little video clip of that. Nasty adenomyosis, and then you get to see this ovarian endometrioma, a bowel lesion, and deep endometriosis there. But while you're learning how to do this, the main thing to learn to start with is the sliding sign, where we're looking internal os torus, just very gentle pressure with your TV probe, just with one hand is fine. You can see bowel moving one way and uterus the other. This is a normal sliding sign. So, Cesarean section scar niche. This again you may well come across in an ambulatory setting. This paper gives you chapter and verse on how to diagnose them, and this is just a little example. A 2D ultrasound again, you can see here that there's a little fluid filled niche where the Cesarean scar is, and it's just a bit thinner. Sometimes this causes intermenstrual bleeding. Here you can see a big niche, and it's filled with menstrual product and clots that just on very gentle pressure is sloshing around the endometrial cavity. The main point of a niche, though, is that it increases the risk of developing a Cesarean scar pregnancy, and that's diagnosed by having an empty uterine cavity, especially at less than 8 weeks gestation, a closed cervix and empty endocervical canal, a placenta and sac deeply embedded in the hysterotomy scar, a negative sliding sign, thin myometrium, and a pole or a yolk sac, and importantly, functional trophoblastic flow on colour Doppler. The main reason for saying this is it's such an important precursor of placenta accreta spectrum, where the placenta attaches deeply into myometrium or surrounding structures, and you get an accreta, increta, or percreta. And this is such a risk for postpartum hemorrhage and peripartum hysterectomy, all because of a deficient section scar. The endometrium, the IETA group, published terms, definitions and measurements, all to describe different kinds of endometrial abnormalities, and they describe in detail about echogenicity, the endometrial line, endomyometrial junction, the presence or absence of intracavitary fluid, colour Doppler, and what the patterns look like. And these are beautiful definitions. They also described how we should be measuring the endometrial thickness, and it is with the probe at 90 degrees to the uterine lie. So like this, you go 90 degrees front to back, And you can also say, what the thickness is, but also where in the menstrual phase is this patient. Is it follicular or luteal, and whether the endometrium is regular or not. These are the different phases. This is post-menstrual or somebody on the mini pill or depot. This is now trilaminar. This is early follicular phase, where you can see 1, 2, 3 lines. This is where the front and the back walls oppose each other. Here you can see in early luteal phase, it's just ovulated. You can see some whiteness coming at the edges, which invaginates the rest of the cavity from outer to inner. So you can see that you get these white little islands with dark in between, and they can look like polyps. So just be careful and always know which phase of the menstrual cycle the patient's in. And then this, in a retroverted uterus, is luteal phase endometrium, where you can no longer count 3 lines. It's all gone white. And here is some post-ovulatory fluid. Fluid in the endometrial cavity is your friend. If you can see fluid, it'll help you to see the endometrium much better. I measure outer to outer and inner to inner, because you then subtract this one from this one. You only have 2 measurements, so it reduces the amount of error per measurement. And you need to look for why is there fluid. In this case, there was some stenosis here, but you need to look very carefully to make sure there's not a lesion. This is an example of an endometrial polyp. So it's again outer to outer, that's the thickness. But here you can see that there is a polyp occupying some of the cavity. And this is brightly white. This is hyperechoic because it's endometrium. So hypoechoic, like myometrium, is a fibroid polyp. White is endometrium and endometrial polyp. Always look, if you see something in the endometrium, look for a feeder vessel. If there's a feeder vessel, it'll be a polyp. If there isn't a feeder vessel, it can still be a polyp, but it might help. And 3D can be very useful if you're just not quite sure what you're looking at. This is a 3D, again in the coronal plane, uterine fundus, endometrial fundus, and this is a lesion in the cavity, hyperechoic. It's an endometrial polyp. In this retroverted uterus, here is a polyp with a feeder vessel in the cervical canal. Women on tamoxifen are at much increased risk of endometrial abnormalities and polyps because, apart from one thing, they cause subendometrial cystic hyperplasia, and so you can't even see the endometrium clearly. You can't measure it. So in women who bleed on tamoxifen, they need a biopsy. You cannot rely on an ultrasound. And we always put colour on just to see if there's something really obvious. But tamoxifen, if people bleed, they need a biopsy. And this is, you can sometimes see really impressive large polyps. Here's one, and there's probably another. There's a bit of fluid around the outside too, and quite vascular too. And then endometrial malignancy, you're less likely to come across this in an ambulatory setting. Mostly these people will come through the PMB clinic, but just some examples in case. This is a hematometra. You need to think very carefully, why is there blood in the cavity? And there's a lot of vascularity here. Maybe this is an endometrial lesion, but such patients obviously need further investigation. In a pyometra, you get a more heterogeneous appearance than a hematometra. And in endometrial cancer, again, this is just a very irregular looking endometrial cavity. When I turn transverse, you can see there is the contents. This is the endomyometrial junction, and here is deep invasion into the myometrium. That can only be a malignancy. And they tend to be very vascular. Asherman syndrome is where there's absent endometrium in parts of the cavity, as in here. You can see these islands of endometrium in the uterus with myometrial adhesions across. So when we scanned this patient later in her cycle, it's not very different. Again, these islands and some myometrial adhesions. And on 3D, this is the endometrial cavity, and you can make an assessment for the percentage of cavity that is occluded. Coils are especially nice to look at in 3D. This is a copper coil in the luteal phase. You can see the arms and you can see the stem in the coronal plane. And you know it's copper because if you turn your gain down, you'll still see it. Whereas if you turn the gain down on a marina, you won't see it. This is a Mirena coil sideways. There's the stem and there are the arms. And in this case, we could see the threads, we could see a bit of coil, but then couldn't find the rest of it. And on 3D, it's really obvious. Cervical canal, endometrial cavity. This is a sideways view. There's the stem, and this is the coil perforated out through the back of the uterus. Here again, we can see some threads. We can see a bit of shadowing there, but in the transverse plane, the cavity was empty. And here you can see that the one arm has perforated and the other one is in the cavity. 2 coils in the cavity. And when they did assure coils, little metal inserts into the interstitial portion of the fallopian tube, 3D was especially nice to visualize whether they were in the right place. This is an example of a very unusual coil. This is it on longitudinal view and on transverse. And this is a Lippes loop, which we used in the 60s. Here is another unusual coil in the longitudinal plane and the transverse plane. You can only see 2 hyperechoic dots. And when you do the 3D, it's a ring. And this is what's called a Chinese ring. This is a coiled stainless steel. It's very difficult to get out. So 3D transvaginal ultrasound in the ambulatory clinic was most useful for all these different applications and indications, but 2D is obviously extremely important as well. Ideally, I think all patients would be scanned in clinic, but of course we'll need to be trained to a high level, and the RCOG has modules for this, and I have a lot of videos online. So thank you for your attention, and if you'd like to reach out, please don't hesitate. Thank you.